هو معانا اونلاين دلوقتي. طيب, it's my privilege to introduce Professor Faiez Zannad. He's Professor of Therapeutics and Cardiology, Head of the Division of Heart Failure, Hypertension and Preventive Cardiology for the Department of Cardiovascular Disease of the Academic Hospital in France. Professor Faiez Zannad has many friends in Egypt. Among them, I'm one of them. We are always eager to hear from Professor Zannad.
Hello, thank you so much. Yes, thank you so much for the very kind introduction. I am so delighted to be with you today and with my old friends. Assalamu alaikum ajma'in.
Alaikum assalam.
So my task in the next 15 minutes or so is to try at least to change the minds of people who believe that with HFpEF we have no options. We do have options, and we do have therapies which are effective, and maybe more so in the near future. So just a historical perspective of the trials in heart failure in general, and you can see that actually heart failure with preserved ejection fraction, we came to this only in the early 2000, while the concept of low ejection fraction has started as a definition by trialists, by the way, just with the trick in order to increase the event rate in trials, in consensus, in SOLVE, for example. And then we moved to these various preserved trial, and you can see the latest one is Paragon and TopCat, and there are a few more coming soon. Now, there have been changes in the definitions, and frankly, I'm not sure that this definition is going to be persisting. Sooner or later, we will have to think about heart failure in other ways than just defined by the ejection fraction. HFpEF was a disease defined by trialists. They created low ejection fraction just for the sake of increasing event rate in trial. And then the diastologist, and I'm pleased that you will have my dear friend Carson Chopper later today. He will discuss about the definition of HFpEF, but you can see that the diastologist agreed not to agree because there is no single definition of HFpEF. Even the cutoff, whether it is 40 or 50 or 60% is not defined, and because of uncertainty, few people have created this new concept of HFmrEF, which is mild range, which is something in between. It does tell you how much this is imprecise, and nobody knows really whether these are two distinct diseases. Well, yet the characteristics of these patients are different. And there is a continuum, by the way, and you can see the HFrEF on the left-hand side, HFmrEF middle, and HFpEF on the right-hand side from very large prospective cohorts, showing basically that HFpEF are older, more women, more hypertension, less myocardial infarction. But the rest of the characteristics are very similar. NT-proBNP is usually lower, but the rest of the characteristics are really, really similar. And then, of course, the event rates are totally different. And you can see that heart failure with preserved ejection fraction, they tend to have similar rates of heart failure hospitalization to HFmrEF, very similar. So these are essentially the same kind of disease. It's only death which is different, cardiovascular death or all-cause death. And indeed, there are lower rates of death in HFpEF than in HFrEF, lower rates, and in addition, different types of death. Most of the deaths in HFpEF are non-cardiovascular. And this is very important to keep in mind. How are you going to be increasing survival in HFpEF with cardiovascular drugs if almost half of the patients die from other causes with multiple comorbidities? So we need to keep that in mind before progressing. And if any, because of the aging population, you can see the trend is that we may have a few more HFpEF and a declining rate of HFrEF, but not it's marginal difference, but there is the persistence is there, and actually half of the patients with heart failure do have HFpEF, so it's a sizable number of population. Now, this is the slide that everybody has shown, whereby you have many positive, effective drugs on the left-hand side with HFrEF, and intentionally blank slide on the right hand because no drug has been validated in HFpEF. This was up to at least a few months ago. Now, the second slide everybody has seen is that sham, I-preserve, PEP-CHF with ACE inhibitors, TopCat with the spironolactone, they usually are shown in this way, neutral results. So none of these medications work, which is not true. This is not true because if you look at sham preserved, indeed the statistical significance was missed hardly 0.005. This is doesn't mean that the drug is worthless. And if you reanalyze the data with subsequent adjustment and account for the repeat hospitalization, which is from now on become standard endpoint in all trials, we do account for the first, but also recurrent heart failure hospitalization. You can see in a reanalysis of this paper published in 2014, 25% reduction of event rate, and this was highly statistically significant. So ARBs are effective in treating HFpEF. Same thing with I-preserve, with irbesartan. You can see on the left-hand side the analysis of the main paper. And we have done reanalysis of these data, adjusting for the baseline characteristics, because bad luck, the baseline characteristics of these patients in the two groups were not equal. They were statistically significant, which of course influenced the event rate long-term. If you adjust for this and get a better balance and comparable patients, groups, then you'll have a highly statistical significant decrease of 11% of event rate. Yet another ARB trial, which is positive. Paragon, which is in ARNI compared to valsartan and RB. So does it make a better job than an ARB? Well, it did. But of course, the study knows that the p-value was 0.059. So everybody would walk home and say, well, this was not statistically significant with the 0.05 cutoff. Okay, this is not the total story. Let me let you know what the Food and Drug Administration heard recently and based their approval of sacubitril valsartan on HFpEF. This is now an approved drug in patients with ejection fraction up to normal value. What they have seen is that they've expanded the composite endpoint as to contain urgent visits for heart failure, for example, not only the classical full admission for heart failure, and then the p-value became below 0.05. They account for the investigator-reported primary endpoints, not adjudicated endpoints, the result was highly statistically significant. And so on and so forth. They have looked at the data from all possible angles because luck 0.059, shall we throw it away? Well, we shouldn't throw away the results of the trial. The trial was positive. And if you look at the totality of evidence, not only the primary endpoint of CV death and heart failure hospitalization, by changing the New York Heart Association, you can see that many more patients improved their New York Heart with sacubitril valsartan, and fewer patients deteriorated their New York Heart with sacubitril valsartan, and this was highly statistically significant. When you look to the KCCQ, which is the quality of life assessment, very clearly there is a clear difference in favor of sacubitril valsartan, improving quality of life beyond placebo. And therefore you have morbidity, mortality, quality of life, and signs and symptoms. Now, you know that in this trial, we have also looked at the renal outcome, whether this drug may preserve renal function, and this is the Kaplan-Meier of the endpoint of terminal renal failure or doubling of creatinine. And you can see there was a highly statistically significant in favor of sacubitril valsartan. On top of valsartan, there was a 50% decrease of severe renal dysfunction, and therefore clearly a kidney protective agent. And therefore the overall results here have been taken into account by the Food and Drug Administration, what we call the totality of evidence, not only the single p-value, which was 0.059, to a point that the FDA has approved this drug now in the United States for the treatment of HFpEF with ejection fraction below normal. Indeed, anything above 50%, the interaction was not impressive, but anything below normal, and actually the Food and Drug Administration didn't venture to give you a number. They leave it to you to decide what is normal ejection fraction. Now, TopCat, it's another story. The left-hand side shows you the full story neutral results. The right-hand side shows you the breakout per continent. The American patients on the top, the trial was positive, highly statistically significant, almost 20% decrease in event rate, compared to Russia and Georgia, where there was no effect. But you can see the event rate in Georgia was so low, one can hardly believe that these were heart failure patients. So what happened here? What happened is that these were faked patients. These were not heart failure patients. Russia and Georgia did a very lousy job. Indeed, you can see the event rate in TopCat Russia and Georgia was hardly a tenth of the event rate in TopCat America and tenth of event rate in Paragon. This was actually the event rate in normal subject in this country. And on the left-hand side, you can see that compared to the United States, to Russia and Georgia, the number of patients taking the drug with detectable, measurable concentration of the drug, 30% in Russia were not taking the drug in the group of patients allocated to spironolactone. So obviously, Russia and Georgia really did not make a service to science, and the investigator in this country had really, deprived the evidence from a high level of evidence. And this is a further observation of poor adherence in these countries. We have looked at this trial and we have reanalyzed the data because it happened that in this trial, patients could be enrolled on the basis of recent history of heart failure hospitalization or high level of BNP. Now, patients who are enrolled on the basis of recent hospitalization, the trial was neutral. But this is so simple to fake a heart failure hospitalization. My suspicion is that investigators got patients, got them to the hospital, they have no disease, and they declared they were hospitalized for heart failure, they enrolled them. And therefore, the trial was neutral. Now, if you can enroll patients on the basis of high BNP, which is a biomarker which ascertains the diagnosis, only patients with high level, then you can see the trial was very positive, 45% decrease in the primary outcome with P001. This is another indication that Russia and Georgia has deprived us from a highly statistically significant trial, but at least this sub-analysis and subsequent analysis need to get spironolactone back on board for treatment of heart failure with preserved ejection fraction. And in addition, and you can see the interaction between spironolactone and Paragon, if patients are taking both medication, they fare much better. 27% statistically significant benefit from the combination of sacubitril/valsartan and spironolactone. So if you can afford both, give your patient both medication. If you can afford only spironolactone because this is cheaper, go for spironolactone. And of course, if you can afford both, it's even better to have your patient on sacubitril/valsartan and spironolactone. So what is next? Certainly, you need to give your patient an angiotensin receptor blocker if you cannot afford sacubitril/valsartan. Spironolactone is so cheap, all your patients with HFpEF should be given this medication, of course, provided they have good renal function above 40 milliliters per minute of eGFR, and combining both is even better. Now, you know that there are new ongoing trials which hopefully will firmly establish the benefit of spironolactone, two trials, one in Europe and the other in Sweden. I'm not going to be into these details, but altogether they will accumulate 5,000 patients. They are ongoing, and hopefully they will come up with much stronger evidence than TopCat. Now, you know that there is a new mirror of the receptor antagonist, non-steroidal, developed by Bayer, with the two immense success stories, the Figaro and Fidelio trial, which has shown in patients with diabetic kidney disease that this finerenone improved outcome and certainly cardiovascular and renal outcome. From there, we have taken this to a HFpEF trial, and this is what we call the Fine Arts trial. I am part of the steering committee of this trial. It has enrolled over 1,500 patients so far. We are aiming at 5,500 patients, and soon we will hear whether non-steroidal mineral alcohol receptor antagonist, which may be safer when it comes to potassium, may be effective in this medication and may add to our armamentarium. And I would like to end up my final slide. Stay tuned. In 2 months now, at the end of month of August, we'll have the ESC late breaker of Emperor Preserved. We got the result very recently. You will see the press release in a couple of days. And in HCC next year, we will have the twin trial, which is called Deliver with dapagliflozin. So you will hear whether at the end of the day, we may also have something new in addition to the existing therapy that I have shared with you already. I will stop here and I would be delighted to answer any question. Thank you so much for your attention.
Thank you, Professor Zannad. Thank you for this great presentation. I am Mahmoud Hassanin.
Hello, Mahmoud.
Hello. My question is, since non-cardiovascular causes of death are so prevalent in HFpEF, do you think that in future trials of heart failure with preserved ejection fraction, should we drop mortality from the primary composite endpoint to get positive results?
Well, actually, trial interpretation needs some open mind and do not be obsessed by the p-value of 0.005. Of course, if it is far enough from 0.005, we can work away. But when it is 0.059, you can look at other data. And this is what we call the concept of totality of evidence. Secondary endpoints, whether they are going in the right direction. Investigator-adjudicated endpoints, whether adjusting for baseline characteristics, we may get you a more statistically significant difference. And this is exactly what happened in iPreserve and CHARM, and the totality of evidence. And indeed, in addition, we're having 2 trials within IRB going in the same direction is what we call external validation, and it adds up to the totality of evidence. So we need to read carefully the trial and not be obsessed only by the p-value of the primary outcome. There are many other things we can learn from trials.
You know, my point of view is that no drug would ever reduce non-cardiovascular mortality in patients with HFpEF. So what's the point of including mortality in the primary endpoint and then getting non-significant results?
Well, you're right. And actually, there is no trial with all-cause mortality in the primary endpoint. It is usually a secondary safety endpoint. Most trials have cardiovascular mortality and heart failure hospitalization, which is the usual endpoint in heart failure trials. And it's fair enough that we may expect that drugs for HFpEF may decrease mortality from cardiovascular causes. But fair enough, we haven't succeeded doing so far. Most of the benefit with HFpEF therapy is decreasing the number of heart failure hospitalization.
Dr. Zannad, I'd like to know the clear universe definition of heart failure with preserved ejection fraction. This is first. The second, what do you think if I claim that this kind of heart failure could be or could mimic the aging, the natural aging process that is a natural process? We can see an old man, 70 years old in Europe or States, compared to another one with hypertension and diabetes, there is no much more difference in exercise capacity between those two. What do you think?
You are perfectly right. Absolutely. I mean, HFpEF is an absolute mixed bag of everything, of normal aging, of hypertension, of diabetes, and of many comorbidities. So it's not a single disease, and you have amyloidosis in some of them. So we really need to dissect this group of patients, these many other phenotypes, and this is what we'll see in the future, I'm sure. On the addition, if we have more drugs effective in HFrEF and HFpEF, like sacubitril valsartan, like spironolactone, and if you have more of these, and we'll hear from SGLT2 inhibitors, then it is quite likely that people will stop thinking about heart failure in HFrEF and HFpEF. If you have a drug which works across all the spectrum of ejection fraction, and we have at least 2 already, 3 classes already, then why bother about ejection fraction? And there may be much smarter ways to define heart failure. Maybe we will get to the universal definition. We have published a recent paper in European Heart Journal encouraging people to think out of the box and out of the ejection fraction, defining heart failure on the basis of the level of NT-proBNP, like you define myocardial infarction, the modern definition, universal definition of myocardial infarction based on troponin. So I'm sure that in the next few months, you will hear more about this, and this is going to be a very important transitional period, including in the understanding, classification, and treatment of heart failure overall.
Thank you, Professor Zannad. I'm Tarek Zawawi from Alexandria. My question about the heart failure with preserved ejection fraction is a heterogeneous disease with different phenotypes. The last recommendation of the European Society of Heart Failure recommend the spironolactone, RAS blockade, and beta blocker as class 2B for the treatment. Which class for which patient to choose? This is my first question. The second, about the Paragon heart study, subgroup analysis found that the women get benefit, 27% risk reduction of the primary endpoint. But what is the explanation for the women? The third question about the new drug. What's your opinion about the new drug like Verscoate, the soluble guanyl cyclase simulator, especially in the phenotype with pulmonary hypertension and right heart failure? And what about the myosin ATPase inhibitor, which recently used for the treatment of HOCM to improve diastolic function?
Well, that's another 20 minutes talk. Many very, very smart questions, by the way. So the latest on myocardiopathy and the myosin activators, we will have to wait, but this is a very good direction into the discussion we are having on subphenotyping. Indeed, there are two types you referred to of heart failure with preserved ejection fraction. One, as a consequence of pulmonary arterial hypertension, the primary pulmonary arterial hypertension, which indeed may be treated with vericiguat or at least guanylyl cyclase stimulators. And the other one is the primitive cardiomyopathy, where by inhibiting the contraction with the excess contractility with a myosin inhibitor may be beneficial. So we will have to wait until we have confirmation of this very promising direction. And if any, what you suggested that indeed in the future we will have to think differently in HFpEF in different classification, and these are 2 of them. Very specific, which may be responding to very specific biologically targeted therapies. Now, I already forgot about the 2 other questions. Can you remind me the 2 first questions?
The benefit from the subgroup analysis of the Paragon trial, the women got benefit 27% reduction. How you explain this?
Well, I don't have any explanation, just that women are different from men. But we have seen these differences in resynchronization, for example, therapy. So there are differences between men and women, and we really have no clue. Of course, we can speculate ad libitum, but whether this is just a chance finding, this is possible. Whether it is a true finding, but we don't have a mechanistic plausibility. And you have a subgroup analysis which may be intriguing. If you don't have a mechanistic, plausible explanation, then I wouldn't really put much emphasis on that, right? Now, the first question I remember now is the ESC Heart Failure Association guidelines, and whereby best you would use any one of the three indicated therapy. Well, I believe there is no preferential benefit from one therapy compared to the other, except the context, again, the subphenotype. So certainly spironolactone, I would not use it in patients with hyperkalemia and or with poor renal function with an eGFR below 40. And the sacubitril valsartan may be more useful in women, but certainly at ejection fraction below 50, but this is because these are the two subgroup analyses which turn out to be very visible. And finally, the beta blocker, obviously it is in HFpEF with the high rate, and this is intuitive, right? So I hope this helps your question.
Professor Zannad, thank you very much. We met together in Cairo 2 years ago in a special meeting. And I asked you a question: if the Paragon trial extended for more than 1 year or 2 years, can we see more beneficial effect for sacubitril valsartan on those patients?
Well, I'm not absolutely sure you heard everything because there was an echo in the room, but my understanding is that whether if the trial has lasted longer, whether we could have captured a sizable and significant effect. Well, I usually don't like this type of argument of lack of power. We lost because lack of power. If we had accrued more events or have more patients enrolled or have a longer follow-up, oh, that's too bad. We may have had a positive trial. I usually don't like this because trials are designed with assumptions of a size of effect. And this hypothesis has to be met by the trial. If we miss, we miss. Then we'll have to do another trial. It may not be necessarily by only adding more patients or prolonging follow-up. So I don't like much blaming the lack of efficacy on the short follow-up or small number of trials. It's just too bad. Maybe the trial was not planned good enough, and we'll have to repeat it.
Dr. Zannad, thank you very much. I am Mohammed Gamal from Asyut. I have a simple question. If we are facing a case of HFpEF and with dyspnea, usually we give our patients diuretic to relieve the pulmonary congestion. What is the second line? It is ARNI, spironolactone, or candesartan?
Well, that's a good question, and actually diuretics are here to stay because congestion is a very important sign and symptom, and therefore you need to use diuretics up to a certain level. When you have decongested patient sufficiently, you may decrease the dose or maybe stop the diuretic therapy altogether, right? But most of patients with HFpEF have hypertension, and they will inevitably need a diuretic therapy. Now, what is the first choice? Well, I mentioned that the benefits are additive, and you shouldn't be upset by the first choice. We have this question all the time in HFpEF as well. We have 4 or 5 foundational therapy, and people keep asking, what is the first choice? There is, the bottom line is that you need to use them all as soon as possible, and if you can afford them all, because I have shown you that if any, the interactions are positive and the benefits are cumulative of spironolactone and ARBs on the one hand, and spironolactone and sacubitril valsartan on the other hand. So if you can afford both, use spironolactone and sacubitril valsartan, or sacubitril valsartan, or NARB and spironolactone. And of course, beta blockers would be on board because most patients have hypertension as well.
We have one last question. I know we have overtaxed you with question.
Yeah,
but it is
one last,
our last question.
short question. Yeah. Thank you, Professor Zannad. I think we have a little bit a clear path as regard the HFrEF, and we were in a dilemma as regard the HFpEF. And in the last couple years, 2 years, we had 2 or 3 steps in a way of 1,000 steps. But do we think that we are having a problem in philosophic overview in the trials? I mean, we are targeting the 2 decades, the former 2 decades, the comorbidities rather than targeting the molecular aspect. Because the comorbidities are a common association with same background of molecular base. And to support my assumption, the aldosterone itself, when targeting the fibrosis and targeting the collagen deposition, etc., it showed too much benefit as regard the clinical benefit in a sector, as you kindly mentioned, in the top cat when the probability was high. And now a lot of trials targeting the C1, CP, all the molecular aspects, and aldosterone showing clear benefit. Do we have, at last, to change our philosophic overview in targeting the trials because we are dealing with comorbidities rather than the etiology or the molecular base?
Yes, well, that's a really very important question, and the pathophysiological understanding of the disease is evolving very fast, and there is a convergence toward the common mechanisms which are the endothelial dysfunction, the extracellular matrix remodeling with fibrosis, and inflammation, right? So many of these targets have been used for different therapies, and the beauty of spironolactone and mineralocorticoid receptor antagonist is it does act on all 3 targets, and this is demonstratable not only in animal study but also in human biomarker study using collagen biomarkers and inflammation biomarkers. And I would like just very quickly to mention a study we have published in European Heart Journal called HOMAGE, Heart Omics and Aging, which was in patients without symptoms, but who have a high risk of progressing to heart failure. And by the way, on echocardiography, most of them have diastolic dysfunction. And in this study, we extensively studied biomarkers using multi-omic proteomic biomarkers. And we could actually show that as compared to baseline, spironolactone influences all the mechanistic pathways we could describe with proteomics that have been shown in animal studies. And basically many, because this drug have ubiquitous and pleiotropic effect, but certainly the most dominant is inflammation and collagen deposition and fibrosis. So we can certainly talk about mechanistically targeted therapy with spironolactone, and there are some hints and papers we have published also from Paragon using biomarkers which show the same thing as well.
Thank you very much, Professor Zannad. We hope to see you in person in Egypt soon. Thank you very much. Bye-bye.
Thank you. Bye-bye.